Funding for HealthLink comes from your contribution to WMHT and the following.
St. Peter's Health Partners takes care of more people in more places all across the greater capital region.
Caring for more people
in more places.
We are St. Peter's Health Partners.
The Dominic Ferrioli Foundation is proud to support HealthLink, a program devoted to discussing a wide variety of issues related to healthy living. The foundation, established in 2001, supports charities throughout the Capital District with a focus on medical services.
Professional hair and makeup design by Rumor Salon and Spa.
Welcome, I'm Benita Zahn, and on this edition of HealthLink, we're going to be exploring a topic that most Americans don't want to discuss: death and dying. Americans, perhaps more than folks in any other country, forestall, if not forego, conversations about end of life. The American zeitgeist is to die with one's boots on, in short, to fight till the end. But a growing body of research finds that in our sophisticated medical world, which is replete with machines that can keep a body going long beyond what was once possible, it's sometimes better to go gentle into that good night. That a branch of medicine called palliative care can provide a better quality of life and a longer life than aggressive care at end of life. We're going to explore this research from many different aspects, and I'm delighted to begin our conversation by welcoming Dr. Mildred Solomon, a bioethicist. Dr. Solomon is the president of the Hastings Center, a nonpartisan bioethics research institute. She's also clinical professor of anesthesia at Harvard Medical School, where she directs the school's fellowship in medical ethics. Her work has shaped national policy on palliative care. And if I shared your whole resume, we'd be here all night. Thank you for joining us.
My pleasure.
I want to start with really sort of a working definition of palliative care, the way you wish everybody would understand what that means.
Palliative care is a specialization of medicine that focuses on improving people's quality of life. It's something that helps you at end of life, as you've mentioned, but also it can be a great source of comfort from the moment of diagnosis. It's really a specialty that is meant to give exquisite attention to pain and symptom management on the physical side of things, and also psychological support to help people make decisions, to provide important overview around their care coordination. Palliative specialists have training in all those areas, so that rather than being a sort of the sum of a bunch of body parts, you know there's a team of people that are looking after you and your interests and helping you grapple with severe illness.
So why is there this tremendous pushback? You know, people feel that if you say you'll do palliative or you accept palliative care, then doctors have written you off, that you're not going to be cared for, that you're not trying anymore.
Right. You're absolutely right. We have lots of ways that we have to make improvements here. There's a lot of progress, though. There's not only pushback. Palliative medicine has only been around as a recognized specialty for 7 years. So it was first recognized in 2007, and many physicians were the shapers and the movers and the shakers that created this field. So there's been a lot of physician leadership and a lot of growth in a very short period of time. In the first 5 years, 83 fellowship programs were established to create palliative, physicians with this set of expertise. And there are now 1,500 hospitals that have palliative care services. And what I particularly like is that the World Health Organization has made a statement that access to palliative care is a human right. But you're right, there's still pushback, and there's still a very long way to go.
There are some doctors who feel that somehow takes away their ability because I can't cure you, so I can't treat you, so you're on your own. I don't want to hear about this palliative stuff.
So there's some misconceptions. A lot of doctors think this means that they're giving up on their patients, and there's no reason for palliative care to be mistaken with hospice, for example. Palliative care is meant to be appropriate from the moment of diagnosis forward, and it's meant to be integrated with cure-oriented care. So that it's unfortunate that there's still that feeling out there. there because that's not at all how it should be practiced.
I once had a doc explain to me as I was researching this that when somebody gets a diagnosis, he likes to see curative, sort of up here, palliative here, and then if things don't really work out, you start moving a little this way so that the palliative becomes the primary type of treatment and the curative, takes a back seat.
Right, but now we've done more research. There was almost diagrams that people created when the field was first beginning, but we now know that if there's early involvement of palliative care, we see enhanced quality of life, reduction in pain, and even a few studies that are suggesting that there's life prolongation.
There was a big study in the New England Journal of Medicine,
yes, exactly,
looking at a type of cancer patient,
yes,
where they lived about 3 months longer.
Exactly right, yes. Yeah. So, we don't have a lot of evidence of that yet, but there's some suggestion that when you're really well cared for, you do better for longer.
If a patient gets a diagnosis, just a bad diagnosis, it doesn't have to be cancer. It could be a lung disease. It could be cardiovascular disease. As a proactive patient, what should you be asking your doctor for?
That's a great question. You know what? We need to give our doctors permission to talk with us about the whole array of things they're worrying about on our behalf. So there's plenty of surveys that show that patients want to talk about these things, but doctors don't know. Some doctors, I don't mean to characterize everybody, but many doctors don't quite know how to begin that conversation. So one thing you can do if you have a distressing diagnosis is let your doctor know that you want him to be, or her, to be square with you.
And then you take it from there.
Yes.
Dr. Sullivan, hang on. We're going to move along in the program now. The American College of Emergency Physicians has an initiative to educate and train its members in end-of-life care to help these people live out their days at home, as studies show they would prefer. But too often when people at end of life present to an emergency department, they're admitted to the ICU and then die there. I recently spoke with Dr. Mark Rosenberg, chair of the emergency medicine and chief of palliative medicine at St. Joseph's Regional Medical Center in Paterson, New Jersey, about his facility's unique approach to keeping people at home. We conducted the interview via a conferencing system at Audio Video Corp in Menands. Welcome, Dr. Rosenberg. So glad that you could join us.
Happy to be here. Thanks for having me.
I want to start by asking you, what was the impetus for you to develop this specialized program within your emergency department for people who were nearing or at end of life?
One of the things that's interesting about end-of-life care is many of the individuals, many of the patients who have serious illness present to the emergency department with end-of-life issues. And I think the big question is why do they present to the emergency department? And they do that because they frequently have unmet needs, whether it's pain or other suffering, that's not managed by their physicians or within their healthcare environment. So they present to the emergency department. So we identified that there was a need, and since there was a need, we developed a program that actually has surpassed our expectations.
What were your expectations for the program?
Well, if you look at the statistics, this is an amazing fact. If you ask people, where would you want to die? Virtually 100% will say they want to die at home or familiar surroundings. And if we look in the United States, 70% of people die in hospitals or healthcare facilities. And out of that 70%, most of those are admitted through the emergency department. Mm-hmm. So our goal was to decrease the amount of people that we're actually admitting with end-of-life concerns and get them into an environment of care that they felt more comfortable and wanted to be in.
Who's on your team?
We have it's a multidisciplinary team. We have a number of physicians. We have care managers, social workers, clergy, and lots of support staff, including pharmacy.
These folks still now have to go back into their community. So you've got this team of people who understand their needs, but now you're sending them back home, and they may still come to a crisis point. How do you support them in the community? How do you ensure that they don't come back through and then end their life in the hospital?
Now, great question. And one of the key points to the emergency department, typically emergency departments are episodic care. It's to manage somebody, take care of them, and then say goodbye. We have actually a transition of care, so we're actually getting somebody who we start the conversation, we start some initiative to improve their care, and we may introduce them to hospice or continued palliative care in the community. We'll talk to their primary care physician. We'll have a family meeting possibly with the patient and their family the next day. They'll be at home. We'll be available by telephone if necessary. But it doesn't stop in the emergency department. It's a whole continuum of care. And many of the patients who we see who would require hospitalization, who may have suffering, whether it's pain or non-pain issues, we may get them involved in hospice. But here's the most important part. If somebody does not want to be admitted to the hospital and comes in with some degree of complaints, whether it's pain or other non-pain symptoms, if I can manage their symptoms and I can actually get them discharged back to home, the patient is happy, the patient goals are met, and we have really just done what was right for the patient, and then continue that with a continued care plan.
Dr. Rosenberg, I spent an evening some weeks back at our local emergency department at Albany Medical Center with one of the physicians who very much embraces palliative care concept. And I said to him, it seems to me you could use a schmoozer, somebody to talk with your patients, because some of these patients haven't even assigned a healthcare proxy. While he didn't disagree, he said if they gave me another salary line, I would want another physician. So how does a hospital do what you did without adding staff?
Let me address what you just said, because it's a very, very important part of what emergency medicine traditionally is and why palliative medicine in the emergency department is so difficult. Emergency physicians may be dealing with a trauma case, so somebody from a car accident, somebody who's seriously burned, somebody who has a heart attack, and they typically don't treat the patient as a person. That's not a bad thing. That's how emergency physicians can go from one seriously ill patient to another, have somebody who dies and go on and take care of a young child who's doing well. In palliative medicine, you have to treat the patient as a person. It's different than what an emergency physician does every day. So when you spoke with the doctor at Albany Medical Center, what he said to you was essentially what I am explaining in other words. You need somebody outside of your clinical environment so that they can actually treat the patient as a person.
And the beeping you just heard is I was keeping tabs so that we wouldn't go over 5 minutes. But okay. Just before I let you go, Dr. Rosenberg, do you have any measure of how successful you are with this program? I know we talked about going back and looking at charts. How do you know if this is really working?
Well, I've been practicing emergency medicine for a lot of years. And all those years that I've been practicing, I rarely get a letter of thank you embracing the care that we do. I may have somebody who we care for in the emergency department, they get admitted to the intensive care unit, and a letter comes thanking the intensive care unit. Every one of my palliative care cases, anybody who's near end of life, anybody who dies, my team or myself get a letter thanking us for the care that we do. And I can share these letters with you. They're all touching, and they all mean a lot to me. It's very rewarding to help somebody in the most serious time of their life, and that is helping them manage their death.
Did you have to add any staff in order to do this?
We use existing staff. We just reorganize it to make this work for our patients. And I'll tell you something, it has helped our staff be much more proud of the care that we give.
Dr. Mark Rosenberg at St. Joseph's Health Care. Thank you so very much. I'd love to stay in touch with you and see how this progresses through the years.
Sounds great. I look forward to it. Thanks so much.
Now, Dr. Rosenberg talked about coordinating with hospice services, and for many, the word is fraught with some negative connotations, and for that reason, it's underused. Dr. George Giokis, Director of Palliative Care for the Community Hospice, joins us now, along with Suzanne O'Brien. Suzanne is a registered nurse, author, speaker, and an end-of-life doula. Now, Suzanne, we know doulas help women have babies.
Yes.
But this is you're turning it on its end.
I am. Doula is a Greek word that means a non-medical person that helps somebody physically, spiritually, and emotionally. It gives comfort to someone else. And I often have said end of life needs the same preparation and love as we do when we're bringing in a life to this world. So it's a positive word used for helping end of life.
How does one help someone at end of life? What does that look like in practice?
In practice, it is actually somebody who stays there for a duration of time, giving the family the education and support to the patient so that the family can be present, and also helping them with the care. Because as we know, we're so afraid of death, especially in this country. And I found at the bedside working for hospice that it was so hard to actually get the families to understand how to care for their loved one who want to be at home. Bringing in the doula holds that space and allows the family to be present.
What do you think about this, Dr. Jokas?
The preparation and the education is key in any healthcare interaction. And most of the time, patients and families know what they want, already know what's happening to them. And again, we're focusing on end-of-life issues now, though, as you said, palliative care is more than just end of life. But at the end of life, most of the time when we meet with patients and families, we're not breaking news to them. They know what's happening already. And if we can help them define what's most important to them, then many times they lead and we can follow and help them, support them, educate them.
What's the figure? Something like the average is somebody spends 3 days utilizing hospice?
Right, so about 50% of patients are on hospice for less than 30 days, and 10% are on for less than 7 days.
Where in this spectrum do you see the doula's work coming?
I see the doula as a bridge to end-of-life care. I see them coming in even prior to hospice if they need that kind of support, like more of a palliative care, but they need the physical 24-hour, the caregiver might be too old and need someone else there, and then having hospice as they come in. I see us as an adjunct because the doula can stay there for the duration, like the birth, like the labor of the birth, and hospice can come in and do their part as well.
How do you get over the negative? You know, a lot of people, the minute they hear hospice, even though, as you say, they know that the end is coming, but it's the acknowledgement. So how do you help people embrace you sooner so they can have that support, the support that Suzanne is talking about too?
Again, meeting the patient and family where they are. And many times that, I don't want to keep on coming back to the hospital. I want to be at home. There's frequently a sense that hospice means giving up and not doing anything. And what you just heard Suzanne say was sort of intensive care, right?
Very much so.
Intensive care. But for some reason, we only think about intensive care intensive care is the ICU. But you're doing intensive care in the home. And so that sense of, no, we're not stepping back, we're actually being very actively involved in taking care of the person.
This all ties in to just what you were talking about,
Absolutely.
Dr. Solomon.
Yes. I do agree that people will respond well when they understand that their care providers are there for them and that this can be a moment for them to make it any way that is meaningful to them.
Now, you talked about having that kind of care. Not everyone can stay at home at the end of their days. So enter specialized homes. They host 2 people at a time and their families as well. If they're they need support as well. We recently visited the Joe Nicole Prince home in Glenville, where Martin Moran's mother, Carol, was cared for. He lives out of town and he wanted to make sure that his mom was well taken care of.
I live 3 hours away. My sisters live nearby. Our anxiety level was rising as things happened. Mom fell at night, in the middle of the night. It was harder to figure out what for her to eat. Literally just moving her, physically figuring out the skills of moving her in bed or how to get her to the restroom. And we were like, and we would ask many questions. But we knew this option existed, but we didn't know if we could get into this amazing place, Joe Nicole Prince home. But the challenges were mounting, and our anxiety was mounting. And right before Thanksgiving of this past year, we found out that a bed was available, and we just, breathed a sigh of relief. And Mom moved in the day before Thanksgiving.
The Joe Nicole Prince home is a place that you come to live and not to die.
But you arrive, you have the round-the-clock care, not only from the skilled professionals who are here all night, who are on staff, but this army of amazing volunteers who are here around the clock. What it gave her was a sense of relaxing into being completely taken care of, knowing that we felt more comfortable. And it gave her more a sense of control. She felt more permission, I think, to let go. When she was home, she didn't want people visiting. She's dying, and they were wanting to see her in her final days.
We provide the 24/7 basic bedside care and a place for the families to come and visit. And we provide some interaction so that the person isn't socially isolated, and then hospice can come in and provide their service. The basic requirements for someone to become a resident is that they are currently under hospice care, that they have a 3-month or less prognosis, and that they sign a DNR.
It's really nearly boundless what this place provides, because at any moment it's a dance of it's being made up on the spot for each resident, their particular needs, their particular situation. Some are here for weeks, some are here for hours. For your loved one, the care is endless. It's how to help them get to the restroom, or how to manage the pain. It releases you from the weight of the specifics of the heavy-duty stuff and freeing you to just be present with the person you love.
There's a need for support and guidance in preparing and making the transition in the relationship, because death is certainly not the end of a relationship, and people start to realize that. And there's lots of closure that happens, lots of assessment of people's lives, taking stock, looking back and maybe making amends or kind of making right some regrets that people have had and reestablishing relationships. There's also a real need in the community for people to be educated on end of life and start talking about death and not have that such a taboo subject.
I mean, the great paradox in life, the great philosophers used to say, in reality, we're living our deaths and dying our lives. Each moment is a kind of letting go. Not in a dark way to say that, but that the thing that's so moving about this place is that it's so full of life, hugely because the souls that are working here recognize the reality of death, not as this dark, dreaded end, but as a fabric of living. We all die. And if you can accept it, it's actually a part of making each day precious.
Places like the Joan Nicole Prince home only have 2 beds. They're wholly reliant on community support. They get no state or federal funding. You can learn about other such homes in the Capital Region by checking out the WMHT HealthLink website. As we watched Martin talk about his experience in that home with his mom, it sounded to me like it was a really sort of coming together of everything that you've all been talking about. Being aware, being comfortable, being comforted, being empowered.
I felt he was so eloquent about the reality of death as a part of the human condition, and that if we can confront that and accept that, we can help each other. And what makes me sad is that there's moments where this becomes polarized. It becomes a football in the public square. And it shouldn't be that, because if there's one thing that unites us all, it's our mortality. And it's often, recently especially, been a target of disinformation and unnecessary polarization, when really this is something we all need to face.
It's not a death panel when you have a conversation about living to your fingertips. Dancers dance to their fingertips. I think my thought on this was how to help people live until they can't.
Exactly.
So if that makes me political, well, so be it. I just think...
It also makes you human. And you can see how grateful that gentleman was. He was just saying on so many levels, that place has 2 beds. Think about all of the population that are in the same situation that don't have that. That's where hospice, that's where palliative care. And the doula, by being there, he said, they take all that stress and allow us to be present. That's his window of opportunity with his loved one at the last time that they can be together, and that's so important. We can never get that back. That's why we want to help that happen.
And does it matter if somebody goes to a hospice, to a home like this, or hospice comes in and helps them? Does the setting matter that much, or is it the support that becomes the key?
So that sense of what is home, and many times we think of home as the physical place, but many times home becomes either the Joan Nicole Prince home, or the home of the nursing home, or even in the hospital. Home is having your family and your loved ones around you, not necessarily a physical place. Because you're absolutely right, many times despite the best efforts of families, the patient is either too sick, too weak, or whatever, that they can't be taken care of at home.
And it sounds to me like it all comes back to something you said early on in the program. The patient, the person, needs to talk to the doc and say, let's talk about me as a person.
Absolutely.
We'll call that the last word. Our thanks to our guest this evening, Dr. Mildred Solomon from the Hastings Center, Suzanne O'Brien, End of Life Doula, Dr. George Giocas. Thank you so much from Hospice and the folks at the Joan Nicole Prince Home. And to all of you, for more information on this topic and to watch episodes, just go to our website, wmht.org/healthlink. And be sure to join me weeknights live at 5 and 6 on News Channel 13 for all your health news. Remember, speak up. It's your life. I'm Benita Zahn. We'll see you next time.
Funding for HealthLink comes from your contribution to WMHT and the following.
St. Peter's Health Partners takes care of more people in more places all across the greater capital region.
Caring for more people.
In more places. We are St. Peter's Health Partners.
The Dominic Ferrioli Foundation is proud to support HealthLink, a program devoted to discussing a wide variety of issues related to healthy living. The foundation, established in 2001, supports charities throughout the Capital District with a focus on medical services.
Professional hair and makeup designed by Rumors Salon and Spa.